This video was made possible by a grant from the American Legion Child Welfare Foundation. You might notice that one of these children looks a little bit different. That's Sam. He was born with a genetic condition called Treacher-Collins syndrome, which results in the underdevelopment of some features of a person's face and head. It occurs rarely, probably not more than once in every 10 to 50,000 births. As you can see, in every other way, Sam is just a regular kid. Yet because of this facial difference, he and his family have had struggles to deal with and decisions to make that other families do not. In this video, you will meet individuals who have Treacher-Collins syndrome and their families. You will meet some of the leading experts in their fields who will shed light on what Treacher-Collins syndrome is and on ways to manage this very complex condition. At its very root, Treacher-Collins syndrome is a genetics problem that scientists still don't understand very well.
At this point in time, we cannot say at all what the Treacher-Collins gene does or what it doesn't do when it's altered because we don't know what it is. All we have at this point is we know there's some sort of a DNA sequence alteration, a mutation, if you will, that causes some problem during development, in the development of the face and the bones of the face.
Dr. Wasmuth and his research team are a part of the Human Genome Project, a select group of scientists around the world who are trying to map the exact location of every gene in each of our 23 pairs of chromosomes.
This is a diagram that shows each of the individual human chromosomes with number 1, the largest, through Y, which is the smallest. And this is human chromosome number 5. In fact, we know that the Treacher-Collins gene is located in this particular region of chromosome number 5, in this general vicinity. And even though it looks relatively small compared to the entire chromosome, or in fact compared to all the human chromosomes, this region probably contains at least 100 to 500 different genes, and the big problem is identifying exactly which one is responsible for Treacher-Collins syndrome. Treacher-Collins syndrome is typical of a kind of an inheritance pattern we call an autosomal dominant pattern of inheritance, which means if either parent has a disorder, such as Treacher-Collins, they have a 50-50 chance of passing that trait on to any one of their children. Treacher-Collins can arise in other ways other than being passed on from a parent because it is one of the class of human genetic disorders in which the frequency of what we call sporadic cases or new mutations is at least 50% and maybe a bit higher, which means neither parent has Treacher-Collins, and yet they have a child who has Treacher-Collins, and so it is something new that happened either in the mother or in the father, and the child has the disorder. However, then once the child has Treacher-Collins, he or she will then have a 50-50 chance of passing the trait on to any one of their children. If parents have a child with Treacher-Collins, it has nothing to do with anything the mother did during pregnancy. In fact, we know in most cases of genetic disorders with a fairly high incidence of new mutations or sporadic cases such as Treacher-Collins, in fact, the new mutation comes from the father rather than the mother. And that doesn't mean the father's done anything wrong either. These are biological accidents. They happen. We can't do much about our genes, and it's sporadic, and nobody's at fault, no matter if it's passed on from a parent to a child or if it's a new mutation. We can't control our genes.
There is no direct way to determine ahead of time if a person has an altered gene which will cause the symptoms of Treacher-Collins syndrome.
There are genetic methods in which you can try and follow the inheritance of the gene through families, but in terms of a direct test, there is nothing available now either for a parent or a fetus. The only way a parent would know if they had the altered Treacher-Collins gene is if they had some symptoms of Treacher-Collins. And in fact, there's certainly some cases where parents probably have very, very minor features of Treacher-Collins and probably don't even know they have it until maybe they have a child who is a bit more severely affected than they are.
A baby's birth. It should be a time of total joy and fulfilled expectations. Sometimes it's not. Most parents of children with Treacher-Collins syndrome recall it as a very difficult time.
So there was not an indication other than I just had a lot of fluid. And then I did have bleeding, and I was rushed to the hospital, and we had an emergency C-section. So I was under anesthesia. So I didn't get to see her until after I came out of it. So I had no idea.
Basically, they rushed her off to the emergency room, took me to there and said, "Sorry, you can't go in for this." And they sent me up to a room where I just paced. And it was a frightful experience for both of us. I know just before they were ready to take Lizzie to the hospital, Allie had just barely come out of it, and they let her hold her, and that was the first that we both had seen her. You're not used to it at that point in time, but there's wires, and she's got the tube out of her mouth, which they intubated her with. So for a few seconds or a few minutes there, they let Allie hold her, and boom, she was off to the hospital down there. And at that point, we started our road trips.
I had to beg to see him right after I came out of recovery. And they brought him into me for no more than 5 or 10 minutes, and then they whisked him away.
And everything was going fine until the actual birth of Jimmy, and then there was dead silence. Nobody would say anything. Everybody, all of a sudden, the anesthesiologist was trying to get me on another topic, and they started talking about California and things like that. And I said, you know, this doesn't seem right, but, you know, I'm behind the drape. And finally, my husband, who was back behind me, he's the one that went and saw that something was definitely wrong.
I think that it's unfortunate that it's not a good experience. I think part of the reason it's not is because we, as healthcare providers, aren't prepared. You know, we don't think about how to you know, approach this, and I think that that's probably how people have a bad experience. You know, the obstetrician or the midwife is shocked, and instead of just being honest with the parents, they, you know, do something that they wouldn't normally do. Put the baby in the isolette without saying anything, or walking out of the room, or, you know, I can imagine any number of ridiculous responses.
And so these families have a lot of regrouping to do, and as well, they feel very isolated. And most of the parents will tell me that when their baby was born, there was no other baby on the OB floor, no other baby in the nursery that had any kind of an abnormal condition, and they felt in the dark. They felt that maybe there was something that they had done to cause this problem, and they didn't know what to expect, and many of them did not even think their children would survive. And so they were in what I would call a very dark period.
I was on my own. All I was trying to deal with was to feed Jimmy all day long and to have him gain weight. Lisa was 13 months old. I had another baby to deal with. My husband was away nights a lot. It was extremely hard. I felt very isolated, and I felt overwhelmed with it all. I just, in the question of why can I deal with this? What am I going to do? It was the unknown.
Not knowing what kind of life Judd was going to have. Was he going to be a vegetable? Would he ever walk? Would he ever talk? Would I have to feed him with a gastrostomy tube? Not that I could not do those things, because I could. It's not that I was afraid to do it or didn't want to do it. I just did not know what I was going to have to do, and no one could tell me. I felt like no one could tell me what I would have to do to make sure that Judd grew up as close to normal and as healthy as he could be.
At the same time parents are dealing with emotional adjustments, there are often critical health care decisions which need to be made. These usually involve 3 functional problems: breathing, feeding, and hearing.
Usually at birth, the first one we worry about is breathing.
When I examine a baby with Treacher Collins, I would probably hook the baby up to an oximeter, which is a little machine that goes either on the palm of the hand or on the large toe, and it can measure the oxygen level.
So for the newborn child, we have to determine whether the breathing is adequate. And sometimes when it isn't, we have to resort to a tracheotomy, where we place a hole in the windpipe and put a tube, and of course that allows the child to get the needed oxygen. We're also concerned about the child's ability to eat. And often when there is a small lower jaw in Treacher Collins syndrome, the children aren't getting adequate nutrition, and of course if they don't get adequate nutrition, they don't grow adequately. So that we work with the families and teaching the parents how to feed the children. And in a few situations, we have to resort to a gastrostomy, which is a tube that is placed directly into the stomach. And of course, hearing is important. And many children with Treacher Collins syndrome have impaired hearing. And it's important that their hearing be evaluated, that they're fitted for hearing aids if it's necessary. You must remember that if a child doesn't hear, that child will not be able to develop speech.
The early times are tough, but at some point, usually after their child's physical problems are addressed, parents begin to refocus on the positive aspects of daily living.
The fact that Judd has Treacher Collins influenced the way I am as a parent or a teacher. Yes, he has these problems. I make allowances for them, but I don't concentrate on those. I look at the whole person instead of just those little parts.
I believe we're closer as a family too, because we've had to do a lot of extracurricular activities that we normally wouldn't have to do. Coming to Dallas for weeks at a time, we get to stay in motels and visit other family members and spend a lot of time doing other things that if Judd did not have Treacher Collins, we wouldn't find ourselves doing.
I'd say right now are the best of times. He's a kick. He's very active. We just have good times. We don't worry so much about the surgeries right now. He's on an even keel. His speech therapy is going well. He just is another kid. He just is one of the kids in the neighborhood, one of the kids at school. We're just a regular, I feel now that we're probably more of a normal, quote unquote, normal family now than ever. Back before, no, I didn't feel that way.
Over time, it started to settle back out. We got Lizzie home. Things started to relax a little better. We were set up for taking care of Elizabeth. Yeah, it was tough at first, but if you stay together and try to be strong with each other and understand that, yeah, there's going to be a flare-up here and there, and just write it off and keep moving.
Treacher Collins syndrome is named for a Scottish physician who, in 1900, described 3 patients who shared common facial characteristics.
The features that make Treacher Collins are that they have an abnormal tongue of hair coming down in front of the ear region. They have a notching of the lower eyelid, and they have absence of the eyelashes of the inner 2/3 of the lower eyelid. Those are absolutes in Treacher Collins. Always have that. They then have underdevelopment of the cheekbones, which can be as extreme as totally absent cheekbones. There's nothing here at all, no cheekbone arch. If you have no cheekbones, the eye slopes downwards because it's got no support. They may have anything from normal ears to small ears to no ears, what we call microtia, which is just a nubbins. The severe children may also have a cleft palate, a hole in the roof of their mouth, and the very severe ones may be missing the top part of the jaw joint, the temporomandibular joint. The mandible or lower jaw grows downwards like this, so the teeth don't meet at the front, and it continues to grow downwards. And if you take an X-ray, it has a very characteristic appearance on the lower surface of the lower jaw. It's called antigonial notching. There's an indentation here, which is characteristic of Treacher Collins. And those children are really very severe because as the mandible grows downwards, it prevents the tongue being kept forwards. So these children can have severe airway problems. They need to be recognized at birth. The bad ones will need a tracheotomy almost immediately after birth. And you can't get that tracheotomy out of a lot of these severe cases until you can take the lower jaw and reposition it forwards and upwards, which will keep the tongue forwards.
There are some common misconceptions about Treacher-Collins syndrome that need correction. Individuals with Treacher-Collins syndrome are not deaf.
To be deaf, you have to have a sensory neural or nerve type impairment, which the Treacher-Collins patients usually do not. Now, a few will have that as well, but most of them have intact and normally functioning inner ears. It's just that the sound doesn't get through to the inner ear because there's no ear canal and there's no eardrum, and the middle ear structures are malformed. But if you can get sound to the inner ear, then their hearing is normal.
Treacher-Collins syndrome is not a deteriorating condition.
Treacher-Collins is not a progressive disease. In other words, what you see in the newborn does not get worse. It does not increase.
Treacher-Collins syndrome is not associated with retardation.
Society, including teachers, employers, used to assume that because someone looked different, they were retarded. And if that happens, you have to confront it head on.
As a general rule, these kids are normal, have normal intelligence.
Learning to deal with challenges head on is a skill families need to develop as soon as possible. The first challenge may be to find appropriate medical treatment.
The more information they gain, the more they'll be positive about the outlook for their child, and the outlook is very good.
When I started out, I was looking for anybody that could tell me anything about Treacher-Collins. I like the team idea because you don't have to go here and have the eyes fixed and there and have the ears fixed and here and they'll do their jaw, and then you have to go down the road a while for them to fix the insides of his ears. Everything is centrally located. It's right here. Everybody knows Judd. Everybody knows us. They know what Judd needs. They're able to say, hey, by the way, we need to do so-and-so. Instead of calling and say, can you come over and talk to me? I'm thinking about doing this type of surgery on Judd. Will it be a problem with anything you're doing? They talk to each other here. They just sit down and they decide together what's going to happen to Judd and what's in the best interest for Judd. That's what's important.
As a doctor, sometimes you can become callous to the idea that the person who's coming to see you with a problem is really a person. I do think of everybody who comes to see me as if they were my child. What would I suggest for my child? If I can't suggest something that I would feel comfortable doing to my own child, I won't do it. I won't suggest anything.
The major craniofacial centers throughout the country utilize the team approach, providing patients with coordinated care and support. Each center brings together surgeons and specialists from dentistry, audiology, speech pathology, psychology, and other disciplines to work with each patient. The result is a unified effort, taking the whole individual into account and eliminates confusion and misinformation. Above all, it is important for families to seek treatment from experienced surgeons and other medical professionals who are truly familiar with Treacher-Collins syndrome and up to date on newly emerging techniques and state-of-the-art care.
There is no place for sending children with either major or minor craniofacial anomalies to a local hospital.
Well, the relationship between the craniofacial team, the local healthcare providers, and the family is very important. And it's really a triad. Most often, the local dental care and the local medical care, the everyday care that's provided for your child will be by your local practitioners. And it's important for the craniofacial surgeon and the craniofacial members to interact with your dentist and with your pediatrician and with you so that everybody works together.
And then I think the greatest assurance is that you can assure these parents that they will receive the benefits, every possible benefit of modern medicine and surgery and teamwork. And I think if you care, and you really do care for them, and the parents realize that you're a caring group, that will sustain them.
Parents often remark that one of the side benefits to having their child treated at a craniofacial center is that it's one place in which families, if only for a few hours, don't have to feel different.
None of us enjoy being different from our peers. We all want to feel comfortable that we are like everybody else. It's a matter of conformity, of being accepted and not being made as an object of ridicule.
A lot of people know this. I mean, little kids, you don't mind if they laugh because I know that they have a problem or something, that they can't control themselves. But grown-ups, I don't know. It's just not right.
How do you handle it?
I handle it fine, I guess, because I just don't think about that. I just do what I need to do and get out.
We wanted people to see what a wonderful little child this is. So we went out, and at first we noticed the people staring, and if someone asked a question, we would answer. And then as time went on, we just became oblivious to it. And now, like Mick said, we don't really care.
Yeah, we just hope that Liz keeps her self-esteem and confidence in herself, that she'll be able to handle any situation that comes up on her own. And that's all we want her to know, is that we're there for her no matter what.
Sharing and support must extend beyond the family.
Maybe not quite sharing, but sharing a somewhat similar experience. I think that's essential for us not to feel alone.
My particular interest in the Treacher-Collins networking started as a result of an incident at a clinic we had here at Children's a number of years ago. We had two boys about age 6 from different parts of the country who met at a session. And from across the room, one saw the other, and he said to his mother, "Look at that boy, he must be my brother. He looks just like me."
Sam was born in 1987, and he was a patient at Children's Hospital in Boston. And when he was several months old, there was a showing on TV of a program called West 57th Street,
which featured one of our patients, a little boy, age 6, with Treacher-Collins. His name was Jonathan. A number of people around this country contacted both Alan and myself and wanted to talk to this amazing little boy who was just phenomenal. And so we kept the names and addresses of these people, we put them together, and then I said to myself, what am I going to do with this now? I want this foundation or this network to really work, to really fly.
When the Treacher-Collins Foundation began, I was surprised that there were 15 families that I could be in contact with. to ask questions to. Today, that list is well over 300, including families and professionals.
This networking between children and their parents is probably something that's going to help them as much in their life as what we do for them surgically, equally, if not in some ways, many more ways.
The Treacher Collins Foundation invites anyone to contact us for information, support, to ask questions, or just to do problem solving or figure out what might possibly be going on in a particular situation. Oftentimes, initial phone calls may last for several hours, and that's okay. That's what this organization is here for.
It's important to remember, Treacher-Collins syndrome does not define the whole person. We should never fall into the trap of trying to explain any individual's life in terms of only one aspect of their total existence.
Well, I try not to think about it because I have a hard time accepting it. I try to occupy myself with the rest of my body. You know, working out, you know, staying overtime at work, to find out how I could apply again to school. I enjoy thinking about what I'm going to do next, you know, and instead of just thinking about, oh, don't forget you got Treacher-Collins syndrome. You know,
Well,
I try to leave that part out.
But when I'm with my family, like, I know that I have Treacher-Collins syndrome. When you're with the strangers, you know, people are like staring at you, pointing at you, so you know you have a Treacher-Collins syndrome. When I'm with my good friends, when I'm by myself, Treacher-Collins syndrome is like nothing. It's like, you know, I don't think about it. It's just me, myself, you know. Just like whenever I look at the mirror, it's like just me. I look okay, I look pretty, you know.
I knew I had Treacher-Collins syndrome, but I wasn't going to let that stop me. I got involved with gymnastics, I got involved with basketball, I got involved with the newspaper. So I got involved with a lot of different things, and I noticed when you act like somebody with Treacher-Collins syndrome, then they'll treat you that way. But if you act like just like everybody else, then they'll treat you like everybody else. And also, but when I'm with my family, I feel like I have Treacher-Collins syndrome. Outside, I'm just like everybody else. And it's just the worst thing, you know. It's usually your family should be there, and they should treat you as just Mary Ann, not somebody with Treacher-Collins syndrome.
Actually, what I noticed the first thing about him was that horrible hearing aid that he had to wear. It was the headband that he told you about before. Yeah. I guess I noticed the difference, but I didn't really think twice about it. It was there, it was him, and it didn't matter. It didn't stand out that much to me.
There's no reason that Treacher-Collins syndrome has to be anything more than an inconvenience, if that much. If you view it as a tragedy, then you're going to pass that on to your child. If you say, well, you know, this is part of life too, everything, without being trite about it, will in fact work out.
We're a good pair. I can't see, he can't hear, so we depend on each other for a lot. No, I don't think that it affects our life. I don't think that we're that different from our friends.
Nikki Sedaris is an absolute inspiration to me. She was the first adult I had ever met with Treacher-Collins syndrome. And I've been friends with Nikki for several years now, and I have watched her in a variety of ways, with her career, with her social life, with her marriage. And if I could plot a course that I would feel really happy for my son to take, I think I would choose some bits and pieces from her life and feel very, very good about it.